As many of you know, the all-on-4 concept is developed by none other than the great Dr. Paulo Malo in Lisbon, Portugal. The concept is actually so simple that it's revolutionary. And I'll go over briefly. What is the minimum number of implants that is needed to support a full life treatment? It was number 4. And 4 implants placed in the canine position and a first molar position will suffice that. But the problem is this. When we place our implant that far back, we often have to do a sinus lifting. And we wanted to avoid that. So therefore, we put the implants a little bit closer together, don't we? But when we do that, what happens? We don't have enough AP spread. So by tilting the implants just a little bit, we can increase the AP spread just a little bit more, and thereby we minimize the cantilever to 1 molar. That's great. And also give us a second advantage, which is we're able to place slightly longer implant, thereby grabbing the dense bone right below the nasal cavity. And this is going to be important. Why? Because we wanted to give our patient fixed prosthesis on the same day, immediate loading. However, because we're angling the implant, we need to find a way to compensate for these angular deviations. How do we do that? There was a company called Nobel Biocare, and they had this ingenious invention, what we call multi-unit abutments that we know today. It can correct angulation all the way up to 30 degrees. And when we place this multi-unit abutment in the patient's mouth on our implant, what we're able to do is provide what we call wraparound fixed prosthetics. This was amazing. This is a surgery I've done 15 years ago during the live surgery, demonstration surgery. Here, we just like Dr. Keeney have demonstrated, I used to do everything analog. We'll have a dentures come in, make the dentures, and we'll do the surgery. We'll place a 2 implant at the lateral position, and we will have a little assessment hole on the anterior wall of the sinus, and we'll tilt our posterior implant so that we can stay away from the sinus, and we can convert the denture on the same day. And what happens is, all of a sudden, voila, they have a fixed bridge. And patients were so happy. So for even a novice surgeon like me, intermediate level, I was able to do this wonderful fixed bridge and teeth in a day for my patient. And of course, from 2004 to 2017, many advancement has happened, didn't it? Digital, guided surgery is one main of them. I started with the Nobel Guide, and then I got introduced to InSequence, and soon later to Chrome Guide, and stackable guides, and I was able to shorten my double arch surgery from 3 hours to 1.5 hours, and that's significant. And year 2017, we reached a monumental number of 1,000 arches. I don't know about you, but for anybody, 1,000 is a lot of arches. Don't you agree? However, when I follow up all my cases, not everything was happy and rosy. And I come to understand that there was some downside of the treatment that I was rendering. And I mind you, these complications don't happen to anybody else but me. Because we don't really often talk about it, but I was not very confident that what I was doing may be the best way of doing so. But what bothered me the most is not about the implant failing here and there, because complications can happen, but how I started to perceive myself was that I felt like a guy with a big hammer. A big hammer. And I started to look at all my patient cases as a nail. And what I'm talking about is bone reduction. Every time I grab my big burr and I'm reducing the bone for prosthetic space or to hide a transition line, there was a little voice in my head telling me, do we really need to remove bone, Mark? Do we? If it was your mouth or your wife's mouth, is this something that you're willing to do? And honestly, I wasn't so sure anymore. Because the reality is this, guys. The ultimate goal of dentistry has always been to restore form, the function, and the longevity in a minimally invasive manner possible. And we call that biologically driven dentistry. And for the past 2 decades, we all worked so hard how to do a minimally invasive, preserving the soft tissue, how to create more tissue, create more bone when we need to. And one of the greatest achievements is that in dentistry, we're able to create something out of nothing. Isn't that wonderful? And this is something that we do routinely now. There's a lot of literature to back it up. It's not even a question of doing immediate implants. It's successful. If that's what we are all trying to aim for, and if this is something like this, we will second guessing, is this acceptable? Why does all the prosthetic has to come to look like this? Those are my cases. Is there a better way for all men and women who get inspired after watching a TED Talk? I went to the bank and got a loan for $10 million and built myself an ultimate implant center. It's an entire fifth floor. It's a 14,000 square foot. And I created an implant center that I only dreamed about. Out of all the facilities that I have, one that I am most proud of and most important was the in-house dental lab. It is my personal research and development center. I have 3 CAD/CAM printers. I have 3 CAD/CAM milling machines, 5 CAD/CAM printers, and I have 7 technicians. And I'm dedicated that, you know what, all I'm going to do is eat, sleep, and learn about implants. So the story goes. I invite you to the concept of NDR FP1 TND. It is a short abbreviation for no bone reduction, fixed prosthetic category 1 teeth next day. And what was important is that I go back to the drawing board. Instead of trying to improve my All-on-4, All-on-X, let's start from the beginning. And I have to rethink everything. Instead of doing a wraparound with a thick pink acrylic or pink porcelain, let's do something different. And instead of using angled multi-unit abutment, let's do without it. Let's go to fixture level. Because we're going to fixture level, let's put implants straight up and down. Because we're doing implants straight up and down, now we've got to place more implant, especially the posterior. That means we need to do sinus lifting. Boy, doesn't sound familiar? But what we get in return, my objective is provide our patient with an FP1. Because, you know what? What we learned over the years is that about the emergence profile, how those immediate implants that we do, how we can design the emergence profile, how to design the pontic so that we get the most optimal tissue response. We know that. So my definition of a full arch treatment was a summation of 2 anterior implants, 2 premolar implant, and 2 immediate molar implant. And when you add them together, joined by pontic, now I have a fixed prosthetics. It's so simple. And in return, what I get rewarded is this. Because I'm not cutting bone, I'm not removing tissue, I don't have to raise big flap. Surgery is minimally invasive. And because I'm only replacing what they're missing, the tissue response is excellent. So when I put the 2 cases together, 2015, this was my typical full arch treatment that I used to do compared to 2020, what I do since then, there's a drastic difference. However, the one biggest difference is that I no longer reduce bone, and by one common goal is immediate loading, because I still wanted to immediately load my cases. Now, that poses a challenge, doesn't it? The challenge is this, and I'm going to explain to you how I've achieved it. And it's the concept of hybrid guide. There's 2 dilemma, 2 obstacles that I face trying to achieve this protocol. Is that one is because I'm not using angled multi-unit abutment, the implant is going straight, and I want an immediate load. That means that I need to find a way to achieve initial stability, good initial stability. And I decide to put 2 parameters together. One is digital, the other one is analog. Let me explain. The term hybrid guide that I use is a combining the precision of a guided surgery and the haptic feedback of a traditional freehand surgery to achieve predictable initial stability. In my opinion, R2 Gate is one of the most accurate guide systems that I've ever used. I haven't been doing implant dentistry as long as Canyon, but I've done fair share, and I've used many guide systems, and R2 is one of the most accurate, especially when it comes to a tissue bone, because I'm not removing bone, it's a tissue bone guide. But however, the problem is this. R2 Gate surgical guide sleeve is at 13 millimeters long. That's one of the longest. That's why it's so accurate. But because there's so much of a friction when I'm trying to fully guide it, I personally had a problem. I couldn't really gauge how tight the bone is. So what I decide to do is that I'll do the initial guide with the R2. I'll go to the maximum distance of 11.5 millimeter, and then I'll remove the guide. And I'm going to freehand it from there on. And the drill of the choice for me that gave me the best haptic response is a denser drill. Not only I use a denser drill to densify the bone, but I can also cut the bone. And the greater thing about denser drill is that it can grow with me because it talks to me. More I use it, I depend on it. And I'm going to follow the discipline, the parameters of how I do immediate implant. 2 implant at the front is going to be 2 immediate anteriors. I'm going to follow all the guidelines. Instead, it's going to be a buccal junket, palatally positioned, and properly positioned, oriented, and because they're going to be joined together. And I'm going to fill all that missing bone area with a sticky bone, which I'm going to talk about a little bit later. Okay? Second dilemma, second challenge for me is because I'm not reducing bone, now I got to grow bone. Opposite, isn't it? And for me, the best way and easiest way to grow bone is using a PRF sticky bone. Many of you probably already know, but for those who don't know what the PRF is, it's just a simple way of drawing some blood from a patient's arm. We spin it a certain RPM protocol, and it makes a bone graft very, very easy to handle. Oftentimes, I don't need anything else but sticky bone. I don't need to use a membrane, and it heals wonderfully. And the third parameter is a design concept, the concept of zero bone loss concept of Thomas Lindqvist. In my implant career, no concept has forced me to put the implant with such a precise depth control. And I call that of a rule of 4 millimeter. What does that mean? The most ideal implant depth when you're doing this protocol is that the implant has to be at least 4 millimeter below the buccal gingiva. When you do that, it has enough of a running room for proper emergence profile of the design, and it gives you the best biological tissue response. And also, when you're designing a temporary prosthesis, it's very, very important that we open up the embrasure. We're so taught to push the tissue, push the tissue. Yeah, you can push the tissue, but when it comes to interproximal embrasure, it is absolutely important that we leave the space open deliberately to allow the tissue to migrate into the natural papilla position. Number 5, immediate loading. We're going to immediate load, not on the same day, but the next day. Why? Because we need time to mill our prosthetics. I'm going to talk about that later. And this patient comes about 1 day later, and we just remove the healing abutment. There's no freezing required. It sits right in, it's screwed on, and occlusion oftentimes is perfect if we plan it properly. And let me tell you a little bit more about that. So, before I finish off, I'm going to show you one case. Okay? There's so many variations, and I cannot show every single cases, but this case, I think, is going to encompass most of the things that I talked about. This is a case that I did 3 years ago. His name is John. John is a 67-year-old man with a little bit of hyperblood pressure, which is well controlled with the medication. Obviously, his teeth are failing. We call it terminal dentition. His chief concern is that he can't chew, he hates his smile, and his teeth hurt. This is intraoral photos. Now, those of you who do full fixed arch cases will agree that this is not an easy case. This is not, any way you slice it, with any technique that you use, okay? Overclosed for many years, uneven plane. His video is a collapse, and we need to create a new occlusion. So these are the recipe, okay? I'm going to place 6 implants, and I'm going to place them 2 weeks post-op, chlorhexidine stain, typical. But look at the 4 months later. Look how beautiful tissue is filling in. Beautifully filling in. A lot of the areas I thought that I need to do connective tissue graft, I didn't have to do it. You give them space and tissue will find it. And then patient's ready for 4 months later for full arch final restoration. We do ISQ reading, look at the Pontic site, and I do a traditional open tray impression. Yeah, you can do photogrammetry, you can do a lot of things, but it doesn't really matter, does it? Whatever, you get a good result. And this is a final prosthetic. A final prosthetic is not a wraparound. Because we're doing a fixture level, we can do a segmented. More basic, the better in my opinion. If this patient ever moves to a different country or different city, any average general dentist can serve this. Nothing fancy. I used to do zygoma, I stopped doing it. Because when the patient move away, nobody wants to take those cases on. And here is the final product, top and bottom. Good old screw-retained, segmented, fixed bridge FP1. Here's the x-ray. Here's the patient, before and after. Now, by this time, though, a lot of you are going to wonder about this. Yeah, that's nice, Mark. You have this big practice with all these machines, 7 in-house lab technicians. What about us? What about us? Well, guess what? I totally get it, okay? Not all you're going to have a research to what I do, but welcome to the world of 3D printing. For many years, I was waiting for this time. When would 3D printing technology evolve so that the material science catch up, so that the strength of the 3D printing material is just as strong as CAD/CAM milling? We're almost there, guys. We're almost there. Now, how I make the temporary immediate bridge, we no longer mill anymore. We print now. We print. Instead of taking such a long time of 4 to 7 hours, we're able to print this 45 minutes, both arches. Now, mind you, you got to do a little bit of staining, but that's easy to do. And what does 3D printers do? They print. They're very affordable. They're easy to maintain. CAD/CAM milling is not easy to maintain, but printing is. So that's how our workflow has changed. This is before and this is after. Over the last several years, we're able to treat many of these patients without having to remove bone. I haven't removed bone for the last 5 years. It is possible. We've done close to 500 arches in the last 5 years. And my practice, I think there's a demand for it because I'm doing an average about 15 to 20 arches a month, and I'm booked until end of August. And so this is my livelihood. And I think there's a definite demand for that. Ultimate goal of dentistry is to restore function, aesthetic, and longevity in a minimally invasive manner possible. And I call that biological-driven planning. And in my honest opinion, with the technology that we have today, I believe that there's no longer need for bone reduction.